Thank you very much. Joseph Chin from CMS.
Thank you, and thank you for inviting CMS to provide comments. The comments I will provide will be in the context of Medicare fee-for-service through our group is responsible for the national coverage determinations. And much of, I think, what was discussed this morning and what I heard on the webcast yesterday, some of the really concepts that we had looked through and thought carefully about while we were actually developing and publishing our decision on next generation sequencing for patients with recurrent relapsed advanced cancers. So I think some of the context, maybe some points to raise from that, what we've encountered in that analysis. So I think initially, our goal really was to provide this type of testing nationally, to these patients, in a broad context. I think we really believed in the value of having this information to drive, targeted therapies. One of the, I think, was some of the points that were discussed yesterday were really some important points we considered in actually looking at the test. So anything that will actually be used to drive a computational method or some type of tool to do that, really depends on the inputs to data. So I think we were very concerned about the validity of the test that we were seeing, which is why I think we really focused on what was FDA approved as a companion diagnostic to initially cover. I think the question about laboratory developed tests and how they are validated, and if that data was really also included into these databases to really drive some of these computational methods, I think that really needs to be evaluated in that sense. I think we also thought about really these large genomic databases such as the NCI Genomic Data Commons, and really how that could be used to support clinical utility and evidence on that, and which is really what as we had placed out in the decision from CMS's standpoint, really wanted to see evidence on clinical utility that actually using the test or using a computational method associated with those tests would actually improve health outcomes. A number of factors related to that, and I think some of the things that we saw, I think we saw similar sort of questions as we had 10, 12 years ago when we were looking at imaging and sort of radiological advancements in PET and CT. I think the American College of Radiology has moved really advanced since then. I think they have a number of very high quality registries. I think we haven't seen that in pathology specifically. So I think the pathologists and their association and the labs need to be engaged in this endeavor to actually be really, I think, a part of it as part of perhaps a multidisciplinary team, cancer board, whereas their role doesn't really stop with just the test. So I think that was really an important point that we came across in our analysis when we were actually doing that. So once these are developed, and I think I'll go to, rest of my comments will be really on how we could actually use this. So assuming that there's valid data entering and valid methods to in this tool that's black box that actually is being talked about, I think what's actually obtained the results, there are mechanisms I think that we have that could be used to really and foster the use to drive decision making, for example, as another decision tool. We have created sort of visits in the past, for example, on shared decision making, where there are evidence-based decision tools that are really used to incorporate into a discussion that's actually reimbursed. We require that specifically, for example, in lung cancer screening, to actually start the screening. So I think once these tools are available and they're validated, and many of the sort of structural constraints that you're talking about and in these last couple of days are addressed, I think there are mechanisms for a payer, for example, to utilize these tools and to actually think about how we can encourage the use through providers, physicians. I think we also saw that the value of genetic counselors, for example, when looking at this because of the complexity of some of the results that you actually get from next generation sequencing. So in that sense, I think we would really be happy to follow along and to see where we can actually participate. We have mechanisms in our decisions to, for example, we had tried to really create a mechanism to encourage collection of data through registries. We used other sort of society registries, specifically the cardiology, radiology, in decisions that actually required them submitting data into these registries for subsequent follow-up. And then we do also internally a lot of data linkages to administrative data. So I think there are some ways that we can actually help try to use these computation methods or tools that actually may be developed. And I think we really think that's where the future, especially in oncology with all this data that we're actually getting, is. I think as one of our first steps really to looking into getting the data was actually the coverage mechanism for those tests. But I think we have other really methods that we could look into to try to assist. Thank you.